Professor Bajaj, you just presented research on using fecal microbiota capsules in patients with recurrent HE. How did this study come about, and what can you tell us about its design and its objectives?
Thank you for this interest in this very underserved population. Patients with cirrhosis and hepatic encephalopathy really are some people who are disadvantaged by the system. And we know in patients with cirrhosis and hepatic encephalopathy, there is a change in the gut-liver-brain axis. So if you change the gut, the patients wake up. However, this system has its limitations because patients on current therapies such as lactulose and rifaximin, etc., still have problems with their cognition, still have problems with multiple episodes. So the question is, the fecal microbial transplant that has been used in diseases such as C. difficile and ulcerative colitis and other forms of inflammatory bowel disease that affect the colon, could we be using them in patients with cirrhosis to affect change in the brain? We have done a study in the past which we used enemas after antibiotics, but of course, patients do not like enemas and they do not like antibiotics, and the giving antibiotics before was a major confounder, and that was also an open label study. So therefore, we wanted to do a placebo-controlled trial with capsules matched with placebo in these patients with cirrhosis, so that we could have a definite answer for at least the safety aspect of this to go beyond just the lower delivery. So we had a lower delivery in short in the past that improved outcomes and was safe. We wanted to follow up with an upper delivery to make sure that that was also safe, and potentially if it gave us a signal for these patients.
What are now the implications of the results, and where are you taking your research next?
So what we found in our results that not only was this safe, this also improved a host of other things that we believe are problematic for our patients. In the people who were given fecal microbial transplant, there was improvement in the microbial composition, there was improvement in the intestinal barrier, there was also improvement in their brain function in selected tests. What we also found that the serious adverse events, which were related to the progression of liver disease, were much lower or significantly lower in people who actually were given fecal transplant as opposed to standard of care. So these are very encouraging results. And when you take this in combination with the prior study that we did, which is the enema study with antibiotics, it gives us great hope to actually combine these routes or actually study them individually. So our next step, which we'll start recruiting shortly, is a phase 2 trial instead of these phase 1 trials with a larger sample size for prevention of hepatic encephalopathy and all-cause hospitalizations in patients with cirrhosis and recurrent hepatic encephalopathy, followed for at least 6 months. We will be doing those patients in some of the patients will get oral and enema together with the active compound. Some of them will get placebo for one route and the active compound for the other. And another group will get placebos for both the upper and lower route. In addition, at 1 month, we will follow them up with another FMT to see the results of not only the both routes, but also repeated FMT in this population.
You concluded your presentation with the statement, the way to the brain is through the gut. However, how do liver patients feel about this type of treatment?
It's not just the liver patients, it is actually a very different paradigm shift. When you tell people that you are going to get stool from another person, however clean and however tested it is, there is a psychological barrier that people have. And a lot of it has to do with just the general concept. Then when they finally get past that concept, the next barrier is, does it smell? And exactly is it like the form of stool? And if those two barriers are a problem, then those patients typically don't agree, regardless of what their situation is. My hope is, like in the C. difficile literature and in the IBD literature, where more and more acceptance happens when people realize that this is actually beneficial, we will get more acceptance. But right now we're in the stage of safety. Next would be the stage of efficacy. And if there's clearly an efficacy signal, then this would be something that we would prescribe to people. And then the patients would describe whether this would still be acceptable to them or not. But right now we are still at a stage where we can only counsel them as part of a research study. But we need efficacy data to have a more convincing argument.
Just because you talked about prescriptions, I believe there are different regulations in different countries regarding stool banks. What does this imply for treatment options?
This is a very frustrating problem for everyone who wants to treat this or study this in a research standpoint. Some countries think of it as a drug, like the United States, and other countries think of it as a tissue, like a transplant, because honestly, it's kind of an ecosystem, an organ that we are actually porting from one person to the other. And therefore, this results in severe discrepancies. You can't do multinational studies without actually making sure things are completely in sync. So right now we are struggling with this situation, but we still need to do national studies before we take this forward. And once we have enough data, again, it goes back to efficacy and safety. If the drug is safe and it's efficacious, then we have a lot more evidence to go to the regulatory agencies and say that can you please make this so that it would be easier for us to prescribe to people from a specific donor or multiple groups of donors.
Well, thank you very much and good luck with your future strive.
Thank you so much.